Today I'm going to present two cases. I'll go fast. First was the anticipated difficult intubation, which turned out to be an easy one on DL-scopy. And second one was a unanticipated difficult intubation, which was a nightmare for us. So this is our first patient, 54-year-old male patient. He had a swelling over the right side of the neck. First of all, it was a nodular swelling, which increased to the present size of 7 to 8 centimeter. Apart from the swelling, he had no other complaints like no difficulty in degglutination, breathing, or pain in that area. As it was proven preoperatively in FNAC, it was a follicular carcinoma of thyroid. So related to thyroid, there was no positive history of hypo or hyperthyroidism, no history of change in voice or hoarseness. That means the swelling was not invading the nerves. In past history, he had no other comorbidities. Family history in this case, I was not much concerned as it was a follicular carcinoma. If it had been medullary, I would like to ask about the Cowden's, familial adenomatous polyposis, and mange syndrome. In personal history, the patient had no addictions, no history of sleep disturbances or snoring. General examination, the BMI was 29, but the patient was comfortable in both supine and sitting positions. Left side JVP was not traced, right could not be assessed due to the swelling. Pulse and BP were in the normal range. IV access was good. On local examination, it was a 7 to 8 centimeter in size, extending from the lower border of the thyroid to the right side angle of mandible. It was firm to hard in consistency and moving with degglutination. It was not fixed to strap muscles. Neck movements extension was normal. Difficulty in flexion was there due to the swelling. Neck circumference was 38 centimeter. He had a short and thick neck, but the circumference was increased due to the swelling. No beard. Airway examination, only the positive points I would like to mention. The MPC was grade 3. Teeth, lower incisors, crowded lower incisors were there. Mandible was receding. Lower incisors cannot bite the upper lip. Regarding mandibular space, the thyromental distance was borderline 6.5 centimeters. So it was anticipated difficult, but possible. Higher mental distance 5 centimeter, which was grade 2. As they say, the ratio of height to thyromental distance is a better predictor than the thyromental distance. So it was 24.5, which was slightly higher than the mentioned criteria, which was 23.5 centimeter. Below that was an easy intubation. Sternomental distance, though it is a good has good sensitivity and specificity, I did not take it as I was not knowing about that. This was the patient. In the third picture, we can see the swelling on the right side of the neck. Systemic examination, there was nothing significant. Blood reports were normal, including the thyroid profile. This was the sono-guided picture which we took just before inducing the patient. Sorry. Here we can see the large swelling, which is pushing the trachea to the left. We explained the risk of difficult intubation to the patient and also gave him the idea if conventional intubation fails, we might have to wake him up and do the awake fiber optic.
Good morning, sir.
Screen दिसत नाहीये.
अच्छा.
नाही स्क्रीन दिसते सर मला. मला नाही दिसत आहे.
We all can see the screen, sir.
मला दिसतंय.
Yeah,
I can also see.
Can see the screen.
Okay. Should I continue?
Yeah, please, madam, continue.
Okay. Two conventional anesthetists were present. Me and Sujata madam were there, and we had a standby fiber optic. After pre-medication and routine induction of propofol dose, after confirming the ventilation, it was an easy ventilation. So we gave scoline 100 milligram IV. On DL-scopy, we saw that the vocal cords were pushed to extreme left, which on external manipulation, we were able to see It was Cl2 and patient could be intubated easily. There was no episode of desaturation in that. Rest of the course was normal and the patient was extubated on table. This was the case too. He was a 58-year-old patient, diagnosed case of CA soft palate, which was extending up to the hard palate, and it was creating a oronasal fistula. Because of the fistula, patient was not able to eat properly. Otherwise, he didn't have any complaints of dysphagia or dyspnea stridor. In positive history, he was of course a chronic tobacco chewer, and he was post-radiation 30 cycle, which was given 7 months back. Other than that, he had no other comorbidities, no history of dysphagia, dysphonia, or breathing difficulty. General examination was normal. Airway examination, all parameters were absolutely normal. No restriction of neck as it is expected in post-RT patient, but there was nothing like that. Thyromental and all distances were normal. On radiology, I don't have the films. The CT scan show ulcerative growth in the soft palate region, which was encroaching about the heart into the hard palate. The maximum axial dimensions were 3 by 2 centimeter. With 2 anesthetists, we decided to go ahead with routine induction as we were able to ventilate the patient. The mouth opening was good and the LMA was kept ready. If any difficulty in ventilation, the fistula can be negotiated and we could ventilate the patient. Of course, fiber optic was standby, and the surgeon had already planned tracheostomy electively post procedure, so it was also tracheostomy equipment was ready. On DL scopy, we found this picture. First of all, we couldn't recognize that what this picture is. It a mass or something? But later we realized that it was the epiglottis, which was large, edematous, and distorted due to radiation. And we were unable to see vocal cords. This is the post-operative endoscopic picture which I got, but on DL scopy the picture was much worse. In first attempt, I could not identify the structures. In second attempt, esophageal intubation does, as not sure which was the opening. In the third attempt, madam only took over and we could intubate the patient with some help of surgeon. And but saturation was maintained throughout the procedure as it was an easy ventilation. So in the third attempt, we could intubate that patient. Tracheostomy was done post-intubation as it was decided. As the swelling was crossing the midline and it was they had to remove the nasal septum. The nasal septum and hard palate were removed intraoperatively and defect was closed with temporalis flap. Post-procedure reversal given and patient was shifted on TPs with tracheostomy on spontaneous breathing. Rest of the course was normal, it was uneventful. First case was a case of anticipated difficult intubation, which turned out to be an easy one on DL scopy. Second case, not so difficult anticipated, but turned out to be a nightmare for us. I would like to throw some light on post-radiation patients, as at Krupamayi, we get most of the patients who are post-RT. So nowadays, neoadjuvant therapy, which compromises either chemo, radio, and immunotherapy, which is given before surgical resection of the tumor, as it reduces the size of the tumor and also distant metastasis, which is good for the surgeon, but at the same time, they also target the non-malignant cells and thereby induce toxicity, which can worsen a patient's health, and it is therefore important for us. Radiotherapy for head and neck cancer, it is associated with many adverse effects like mucositis, dry mouth, osteonecrosis, trismus, and dysphagia. Most of the patients, they came with trismus only. Moreover, it targets the neck. So patients many times develop hypo or hyperthyroidism. So it is better to do a thyroid profile beforehand in these patients. Difficulties also arise in mask holding because decreased tissue resilience of the neck because of the radiation and decreased mobility. Laryngoscopy may be difficult because of fibrosis, trismus, or restrictions in mouth opening, and also glottic and epiglottic edema, which may impede the visualization of the normal anatomy. Though no one has prescribed any specific criteria for predicting a difficult airway in post-radiation patients, some factors can be considered in addition to our routine difficult airway assessment. 4 Ds, dysphonia, drooling, dysphagia, and dyspnea for epiglottitis and glottic edema, but surprisingly our patient had nothing of them. Time to surgery, that is after radiation, the time gap between the surgery, more the time gap, it is better for us. It is, we get time for healing, the edema reduces, but still the fibrosis and all they develop. And the time to surgery is not in our hand, as surgeons decides it because of the prognosis of the disease. More chances of airway edema if the patient received radiation to bilateral neck. If we suspect epiglottitis, we could do lateral X-ray neck, in which we can see the classic thumbprint sign, which has a, not in all cases we can see that. Ultrasound recently is a very nice predictor of difficult airway in these patients. Though we are in a very learning phase of this, but we can do this for every patient as it can be done bedside with the sonocyte. It measures some of the, parameters like anterior neck soft tissue thickness at the level of vocal cords, depth of the preepiglottis space. And we can predict the difficult airway with this cheap and easy available sonocyte. Thank you.